Hello everyone. I'm Viral Shah from Indiana University, and I have a pleasure to moderate this session. The session is about GLP-1 and other adjunctive therapies for glycemic outcomes. We have four speakers. Each speakers are given 10 minutes to present, and then we will have a 5 minutes of Q&A. So this session will be for 1 hour. So the first speaker is Dr. David Hansen from SUNY Upstate. David, okay, come on in, and I'm looking forward to all the presentation and learn. This is one of the area that I'm very interested on adjunctive therapies in type 1 diabetes management.
Good morning, everyone. It's great to be here. It's been a wonderful 2 days so far. So I do have an acknowledgement slide at the end, but I just want to say from the beginning, I'm really grateful for our QI team. Joe had the award for helping with peds and adults, and Drusha is super helpful with all this data. So I'm very appreciative of them. Working on advancing here. Nope, not that one. So there we go. Got it. Okay, we're good. Up, down, good. Okay. So this is a recap of what our program has done in the past few years. And so I'm going to try to be efficient because we have lots of really other interesting speakers and topics that are going to be presented today. So we want to make sure we have time to get to all of that. So our program is designed to support individuals who may be at higher risk for diabetic ketoacidosis. And so we've identified people by looking at recent admissions to the hospital or who have an A1C that is 9% or above. If anyone was able to be at the remote monitoring diabetes data session yesterday, a lot of cool things that we could add into this based on that information. So I look forward to hopefully incorporating that. Our goal is to decrease admissions, improve, A1C, and most importantly, the quality of life for the people in the program. So, again, at prior sessions, we've gone over this in more detail, but these are the different items that we're looking at that might be contributing to some of the issues. And again, there's nothing new or surprising on here, but even though we're in a state that is actually pretty well supported with transportation and Medicaid cabs and stuff like that, that still is a pretty huge barrier. So just working with all of these things to help out our patients. This was our initial curriculum. It's just presented here. It was a little bit more regimented. We had the first visit and we had what we were going to go through for that visit. We had the next visit and that was planned out. In our subsequent iterations, we've been a little bit more flexible with what the different patients have wanted to talk about and what they may need more specific help with. So some of the changes for our most recent cohorts, it's now kind of a rolling admission program, whereas initially it was a fixed number of people while we made sure we had enough resources to help everyone. But we added some more visits, so there was a little bit more flexibility to focus on what each individual needed. And we were very fortunate to have a psychologist added to our team. That's been a really wonderful addition to the program. And she'll meet with the participants if they want to over a short term and then try to connect them with someone more local because we have a decently large catchment area and it's not always feasible for them to come long term. Of course, the social worker is extremely helpful as well. And we had a pretty strict kind of return to usual care, meaning no longer involved in the program if there was a certain number of missed visits and or other factors, cancels, no-shows, which we eliminated for this cohort, these two. So this is a 2024 cohort. It leaned a little bit more female than male, and again, there's a little bit more with public insurance rather than private. You can see kind of the A1C changes at the bottom there between the two groups. On the far right, the people that did not complete the whole program didn't have much of a change in their A1C. And on the left, again, there was at least some change in the mean A1C. This graph is showing what the different individuals' A1Cs were at the start of the program, when they completed the program, and then 6 months after. The one that's missing finished. We don't have the 6 month data yet for that person. That's why it's missing. But in general, you can see there's generally some improvement for everyone, even if there's maybe a little bit of higher numbers part through. I think something in the program stuck and helped out the individuals later on. So our 2025 cohort is a little bit flipped, and there tends to be more male participants in this group than the prior group, still with more public insurance, and we don't have the follow-up quite yet. One thing on our next slide that you'll see, I think, is important to think about kind of the individuals, because what will stick out in the 2025 cohort is that when we're looking at the DKA events, one of our individuals had 24 out of the 35 for the whole group, obviously not what anyone wants. And that individual is doing better, but in our data, they're going to be still having some episodes of DKA, but throughout the year, instead of coming in obtunded or very tired and not responsive, the individual is recognizing things sooner, getting to the ED sooner, has actually come in twice now and not been in DK at all. So even though some of these things may not show up in kind of the broader data set, I think the program has helped him quite a lot. And just again, focusing on him, there's some barriers there with insurance and pumps, and he won't want to check and those sort of things. And so the insurance won't start the pump. So we're just working really closely with him, and hopefully it'll just help him have a better life. So next steps, again, we need to finish out this cohort and see what changes we need. One of the things I'm looking forward to doing is adding a questionnaire for the individuals to see what actually helped them the most. I think sometimes we might like to think it's all our education and stuff, but I have a feeling it's being connected with the educators who are communicating with them, making them feel like they have someone who really cares about them outside of their immediate support group. And so we'll see if that is an accurate thought or not. But I think that's been a huge help, and our educators have been really, really amazing with this. And again, coming up with other changes based on that feedback. So these are all the people involved, highlighting especially the educators, psychologist, our social worker, child life dietitian, and then our QI team I mentioned, and then our management that lets us do all these things. So that's what I have for now, and I'm open to any questions.
All right, thank you so much. And finishing up before time. Any questions? And I can probably start with that. So that one individual at 24 admission.
Yes.
What's going on here?
So our clinic sees people through 21, and so he is an adult, and a lot of times we'll be able to get some extra services involved, and we haven't in that case. He has some mental health concerns as well, and very, very little support at home. So he's trying to bridge the gap, live on his own, and he knows what to do, but if depression or anxiety comes too much, kind of falls into some prior habits that aren't helping him stay out of DKA.
Yeah, and the reason why I asked that, I think, in Colorado when I was there, I think we did a lot of research on marijuana and type 1 diabetes, and what we realizes that those recurrent EKs are not really due to diabetes. It's because of cannabinoid hyperemesis syndrome.
Mm-hmm.
And I was just very curious that is that something? And then most people, at least in our studies, were using cannabis for anxiety, depression, and some of the reasons for their mental issues. And so I was just like curious to see like, is that something happening here? It's really related to diabetes, but
Yeah, we have been able to transition to more, prescription pharmaceuticals to help with some of those concerns. So hopefully, I agree that will be good for the future.
any other questions? No question? Easy. Okay. All right. And we're going to move on to the second speaker. So our second speaker is Dr. Jody Grundman, and she's going to talk about the blossoming outcomes, a multidisciplinary model for youth with type 1 diabetes and suboptimal glycemic control. So stage is yours.
Thank you. All right. Good morning, everybody. So for my talk today, I'm going to be talking about a clinical program that we do at Children's National called the Blossom Clinic. So just a little bit about our center. We take care of approximately 1,600 youth with type 1 diabetes, and we have a very diverse patient population, both in terms of race and ethnicity and insurance status. You can see on the right there, we have a pretty good proportion of patients actively using CGM, but our group is very passionate and dedicated to improving our AID use as well. So a little bit of background, this has been discussed extensively over the past day and a half, but youth with type 1 diabetes and suboptimal glycemic control have a lot of barriers to care and achieving the outcomes that we're asking them to achieve that are very difficult to address in the standard outpatient care model. So our group really wanted to focus on these patients with higher needs and higher barriers to improve their glycemic control and outcomes. And we aimed to do this with a program called the Blossom Clinic, where the aim of this program was to increase CGM and AID initiation to greater than 80% and reduce HbA1c in a clinically meaningful way among participants in the program. So a little bit about the Blossom Clinic. We called it the Blossom Clinic because it's in Washington, D.C., and we wanted a positive connotation, not regardless of what's going on with the politics at the time. And one of our awesome educators, Kim, actually came up with the name, so we have her to thank. So the program is open to patients 6 to 18 years old who have had at least 2 A1Cs of 10 or greater or 2 or more DKA admissions in the past year. And it consists of clinic visits once every 3 months for a total of 4 visits over a 12-month period. And it's an interdisciplinary team, which consists of a provider, a diabetes educator, psychologist, social worker, pharmacist, and health coach. And these are all members of our diabetes team that we are fortunate to have in our diabetes program. And I was able to convince them to join me on this effort to help our patients with the highest needs. Okay, so there's a couple things that the program focuses on. So first is interdisciplinary care. We start each clinic with a team huddle where we discuss the patients extensively and everybody kind of gives their input or concerns around the patient and the things that we feel that we need to address before the patient comes in that day. And the visits are extended. We typically have like 30 minutes for follow-up patients with diabetes, but these are blocked for 2 hours. And then, like I said, the program is 4 visits over a 12-month period. And once you get to the final fourth visit, the team discusses if they've reached the goals that we've been aiming for them. And then we discuss if the if the patient is ready to transition back to routine care, or sometimes we do keep them until we feel that they have achieved the goals that we were aiming for. So they're not necessarily done at 12 months. We do try to individualize it to the patient needs and their timeline. It's very patient and family centered, so we do make a very strong effort to engage in shared decision making and set goals with the patient and the family. And we do have between visit touch points that can consist of the provider reaching out or other members of the team following up on things that were discussed at the visit or come up in between visits. And we also use screening tools to assess for depression, anxiety, social determinants of health. So all different screening tools, diabetes knowledge, health numeracy. So we are engaging in screeners as well as the pre-visit huddles to kind of assess their needs and identify things that might not come up from just chart review or discussions with the families. There is a very strong equity focus, like everything that we do at our center. So through this clinic, we are able to offer help with transportation. That can be in the form of gas cards, Uber, parking vouchers. We have an amazing food pharmacy program that we just run out of the clinic. So we utilize that for the Blossom Clinic as well for anybody who screens positive for food insecurity. We're also able to offer them diabetes supplies. So we do give them ketone strips because often those are not covered by insurance. So we do offer those at every visit as well. And then we have a very strong focus on technology support. As you saw in our previous slide, we do have suboptimal uptake and sustained use of diabetes technology. So we do have a very strong focus of trying to help support patients to uptake and sustainably use both CGM and AID. We give out extra sensors to help with gaps in supplies, which we know is a very common issue. And we also give out CGM adhesives to try and overcome barriers with wear and improve satisfaction with the devices. All right, so the rest of the talk, I'm just going to be discussing results from the first 12 patients who have completed the program. So we're just a little bit over a year into running the program. So the average age was 12.8 years with a mean duration of 4.9 years of having diabetes. And the median A1C at baseline was 11.9. And you can see here that we have a predominantly non-Hispanic, Black, and public health insurance cohort where the technology use is even less than our general population. So a lower proportion of patients using CGM and a lower proportion of patients using AID. All right, so the first clinical outcome that was very exciting was we did see an overall reduction of HbA1c from 11.6 to 9.9 in the 12 patients who completed the program. Our DKA events per patient were not as exciting. There was like a spike in the events from visit 1 to visit 2. There was one patient who actually had like 2 ER visits between those two time points. So that might be a little bit of an outlier, but doesn't look like we've made any major improvements in DKA and ER visits in the cohort quite yet. CGM use, we have had a mild increase in active CGM use. We had 2 patients that at both visit 3 and 4 had stopped using CGM between visits, and then we reinitiated it at that time. So still having issues with sustained use, even though we continue to restart it every time they come into clinic, which is similar to what we see in our regular care. And then with AID use, we did see an increase in active AID use. And more exciting is that we actually have 2 patients that started AID after the final visit. So we did have patients that were engaging in AID education at the clinic visits, and then we're starting AID. So that was exciting. That percentage goes up to like 75% with the 2 that started it after completing the Blossom Clinic program. In terms of engagement, on average, they met with 3 team members per visit. So at the initial visit, they pretty much meet with everybody for the first time, and then it's kind of as needed from there on out. And excitingly, we did have 100% retention. So all of these patients did go to all 4 visits. So that was very exciting. And as I said, of those that did not have AID at the beginning of the program, 63% did receive education throughout the program. All right, so in conclusion, it seems that a multidisciplinary equity-focused design is feasible and acceptable among our patients with complex needs. And there was a very strong engagement with the multidisciplinary team. And it does seem like there have been some improvements in the things that we set out to achieve, which is exciting. But there's a lot that we still need to do. So we are looking to expand enrollment and grow the program. We're looking to, it's QI, right? So we're refining workflows all the time. We're meeting with all the members of our team to ask what's going well, what's not going well, and revising our workflows and our huddle and our between visit check-ins. We're not yet achieving those goals we set for technology sustained use. So we have been actively discussing how we can more finely tailor our strategies to a population with higher and more complex needs and higher barriers to make it more successful. And we continue to collect, longitudinal data on outcomes and look to see how we can kind of scale this and spread it to other locations, because right now we're only doing it out of the main hospital, so making it more accessible. And of course, I just have to say thank you to the amazing team, because everybody added this to their work plate, to all the work they're already doing for our patients. And everybody was so enthusiastic to get on board and help our patients. So I just need to say thank you. A lot of them are in the room now. And that's it.
Great presentation, wonderful work. Any questions?
Thank you for your presentation. Just curious, of the 12 patients, did you have any dropouts from the program? The first presenter said 4 patients dropped out. So I'm just curious if you had any patient.
Yeah, so from the 12, these are the 12 that finished the program. So yes, we've had a couple of patients who have not come to scheduled appointments, and we tried to reschedule them a total of 3 times before we dismiss them from the program, because right now we have such a limited capability and want to make sure we're providing opportunities to people who want to be in the program. So I don't know the exact number. We have somewhere around like 40 patients that are actively in the program, and I think we've had like 3 or 4 that have fallen out of the program.
Hi, Christy Corley from Grady Health System. I love that you have such a robust multidisciplinary team. I was wondering what the role of your pharmacist was.
Great question. Yeah, we're so lucky to have a pharmacist. So that was kind of like a superpower that I think is not common to have. So through like PDSA cycles, we actually like refined her role. So in our pre-clinic huddle, she will actually have reviewed, do they have active insurance? Are they consistently filling their refills, both their tech supplies specifically, because sometimes they're getting them differently from pharmacy or DME. She can tell us when the last time they picked up their refills. And then she can like meet with the families to discuss if they're having any barriers to picking up their supplies. The other thing that we're really fortunate to have that just started since starting Blossom is we have like a specialty pharmacy in our hospital that can do scheduled deliveries of supplies, but it's contingent on families picking up the phone to confirm that they will receive the supplies. So we're very often switching families to that option in agreement that they'll be able to, pick up the phone. So we've been really, really lucky to address a lot of barriers around supplies and gaps in supplies with our pharmacist.
Hi, Carla Demeter-Bergum from Rady Children's Hospital, San Diego. First of all, congratulations. This is really music to my ears. Patient and family center care is what we should look for. I wonder if you could comment in terms of, balance measures, if we're talking about quality improvement here. such as bandwidth of your team and cost? Is this embedded already in the insurance, or do you have any other source of funding? And how did you do for bandwidth of everybody's time?
Yeah, great question. So right now we don't have funding. We're looking to get a grant. We're kind of using this as like a pilot to try and collect data and say like, hey, this is feasible. We're achieving outcomes and, we would like more resources. So right now, these are all resources that we have available in our clinic. We have been using some of our social work funds for some of those supplies and transportation finances to help fund those out of, routine care things. Yeah, was there more to the question? I don't remember.
For pumps and specialty medication, did not be able to convince them. That is something that we should look with. I'm curious because suggestions, recommendations that how to make them identify.
Sure. So the question, which was a good question, was saying that there's a specialty pharmacy that's able to supply GLP-1s and other diabetes supplies, but not insulin, and how to convince specialty pharmacies to supply insulin. That doesn't make any sense to me. I don't know why they would decide to, fund everything but the most, pressing diabetes supply. So I am not sure how that decision is made, but I think like with everything in QI or research, right? It's like, do you have the data and can you like look at your patients and like the supplies and what they're able to pick up and what they're not able to pick up, and maybe making a case for like, hey, this is a real need and they're needing insulin consistently for their entire lives. And this is something that we should be, offering them because they would definitely be utilizing it.
The question. Yeah, but I'm going to ask you one more question. Sorry. Yeah. I was just curious, like in your cohort, the people were started on a CGM, but then you had to restart because they didn't use it or probably didn't want to, or whatever the reasons. Did you try to analyze what were the reasons?
Yeah, so we haven't been collecting like concrete data on that, but it's like a very common thing we see in our clinics all the time. So we always kind of ask about it, right? Like we prep the charts, we see they haven't been wearing it. It's like, what happened? We put it on at the last visit. What are the barriers? A lot of times what comes up in conversation is it fell off, I forgot it was there, it's painful, I don't want it to show. And like we feel that we're addressing the barrier at the visit and then we restart it, but then they come back 3 months later and they're not wearing it. So I think similar to some other talks we were having today, it's not necessarily always coming out in conversation what the true barriers are, and we need to do a better job of trying to figure that out so we can actually make progress, because doing the same thing over and over again is very frustrating for everybody.
Yeah, and the reason I asked is that I think my experience with very few people is that certain people, particularly African American population, somehow that this it's sticky enough to really stay on their skin. And the Eversense has been like really great for those people. And in my opinion, I think the pediatricians generally don't consider that.
Yeah.
The adult side we do, and we don't do a lot of good things, but sometimes we do. And I think one of that part. And so just, that's where I'm throwing up that idea that I think it's not thought about when people are saying that it's not staying on my skin. Yeah, thank you so much. We're going to move on to next speaker. All right, so sorry, I think my phone got messed up here. The third speaker is the Stephanie Crossen, and she's going to speak about the remote patient monitoring for person with type 1 diabetes experiencing elevated glycemic measures. Stephanie, stage is yours.
Thank you. And thank you to whoever adjusted the lighting. Can everyone in the back now see the screen clearly? Like the thumbs up. Thank you. So I really appreciate the chance to present this work today. And before I launch into the presentation, I first want to acknowledge that this was really a joint endeavor between our team at UC Davis and the team at Tidepool. Many of you are in the audience, so a shout out that we really appreciate their amazing collaboration on this work. So as everyone here is aware, we have an unprecedented level of access to our patients' glycemic data these days. It's really incredible for how many of our patients we can look at CGM data between visits. But what we really don't have yet are clinical protocols, figuring out when and how we should be looking at that data, when and how we should be reaching out to them between their visits. The other recent development that's been so exciting is that diabetes data platforms like Tidepool and others now have pop health dashboards. As you saw with some of the screenshots yesterday during the RPM panel, we can risk stratify our patients based on their CGM data, which is really exciting and opens up a lot of possibilities. So for this project in particular, we focused on our patients with type 1 who are experiencing elevated glycemic measures, thinking that they might particularly benefit from between visit contact. And another piece of context I'll add is that we've done several RPM studies at UC Davis, but in the research context, you really can't nail down the clinical workflows and some of the financial feasibility data. So this was our first effort to kind of move RPM from the research into the clinical context and really get a better sense of some of those clinical logistics that we need. So for this program, we enrolled 20 people with type 1 diabetes of at least 1 year duration and at least 3 months of CGM use. And they also had to have an A1C or a GMI at 8% or above. All the participants agreed to 4 months of clinical remote monitoring with the associated outreach from our team and associated billing. And the way we did this is that we generated weekly reports using the Tidepool Tide dashboard to identify patients who met our outreach criteria. So the criteria were anyone with a time in range of less than 30% in the prior week, or a decrease in time in range of 15% or more from the previous week, or hypoglycemia of 5% or greater, or a CGM wear time of less than 70%. So any participant who met at least one of those criteria was contacted that week. And we used a variety of different contact methods. I know there was discussion yesterday a little bit about what can be done over EHR messaging, what can't. We tried for this to start everything with text because in my prior studies and our surveys, people really prefer text outreach. So we actually had a text platform built for this. We were able to text participants directly. But we found, which I'll get to later, that there was not a high response rate over text. So we did end up using phone and EHR messaging as well in this cohort. And the contact person varied as well. So this was primarily myself and a program navigator doing this program. When it was a CGM wear time outreach, she was the primary contact, would get more information about supply issues, skincare issues, anything that was really impacting wear time. And then she would pull in members of our clinical team as needed to address those concerns. When it was a time in range or a hypoglycemia criteria, it was usually myself looking at their glycemic data and then reaching out with clinical recommendations. So this is our cohort. As you can see, they were a majority adolescent with a mean age between 13 and 14, a little over half female, half publicly insured, a mix of race and ethnicities, and they had a mean type 1 duration of 5 years, a mean baseline A1C around 9.5. And interestingly, 70% of this cohort were already using AID. And this was interesting to me because the prior studies I've done of RPM were, even just 5 years ago, the AID use was obviously much lower. And what you can achieve through weekly outreach when you're moving towards technology versus when people are already on technology, I've come to find is a very different thing. So first to go over some of the clinical metrics for the program. So people in the program received outreach a median of 6.5 times over the 16 weeks, but there was a wide range. So there were people who never met criteria for outreach, and there were people who met criteria almost every week. The most frequent reasons for outreach were actually time in range less than 30%, which was about half of our outreach events, and then CGM wear time less than 70%, which was a little over a quarter of outreach. The median time spent on outreach events was 10 minutes, but again, there was a broad range from 5 to 60. And I will say that, not surprisingly, phone outreach often took longer, although you got a lot more detail than when you were doing things asynchronously. As I mentioned, we had a quite low response rate to our text messages, so we ended up involving phone outreach 65% of the time, and 41% of our outreach events had no response from participants, even with repeated outreach in different modalities. Despite that, we actually had some notable CGM changes. So in our 20 participants over just 4 months, we did see a significant improvement in time and range from around 34 to around 40%, which was not surprisingly associated with a reduction in time spent above 180. And then we surveyed everyone at the completion of the program. So all of our respondents rated the program as either very helpful or a little helpful, which was interesting to me. It included the people who never once got outreach during the program, but they liked it. I think they thought they had a safety net there. And then 83% of respondents thought that it should continue in some form. And this was a brief survey, and there was some free text, but a lot of it was multiple choice. So we did list a bunch of potential benefits and asked them if they had experienced any of them. And the most frequently endorsed were reminding me to stay focused on diabetes between visits and making it easier to get help managing diabetes between visits, not surprisingly. And then we asked about their preferences, if we were to continue RPM, how it should be done. So over half of them said they preferred weekly outreach, and then a smaller group said monthly. The vast majority, again, said we want to be contacted by text, even though they did not respond to text. And then phone was their second choice. And then when we asked about the goals of RPM, because when you think about it, you could have a variety of different targets for RPM outreach. They overwhelmingly said we want help keeping glucose in target range. And then a smaller group said we want help getting diabetes supplies. So I will preface this slide with several caveats. If anyone here has tried to get reimbursement data, you probably understand this pain, but it is very difficult to get complete and accurate reimbursement data. It's also highly delayed, so the reimbursement doesn't come in until at least 4 months after the charges are dropped. We also had a subset who were on managed care plans where there were contracted rates, and it was hard to pull out RPM fees from that. But that being said, here's the data I was able to glean from this. So for our 20 participants over 4 months, we were billing monthly, and these are the RPM codes that we use. So 99453 is the setup code that was billed at the beginning. 99454 is the monthly facility charge that's for reviewing at least 16 days of data. And then 99457 and 8 are the professional charges, where if you've had any synchronous communication and at least 20 minutes of time spent total that month, you can bill those codes. So we use these codes throughout, and for the whole program, the RPM charges totaled a little over 26,000, and the reimbursements that came back were just over 8,000. So about $100 per patient per month for this cohort and payer mix. And I say that because as I've iterated through several RPM projects, I think it really depends on your cohort, your goals, your frequency of outreach. A lot of things are going to determine what kind of charges you can drop and what reimbursement you get. The charge ranges that are shown here for public and private insurance plans are among paid claims. So there were a lot of claims that were just denied, but among those that actually were paid, these were the ranges that we got reimbursed for these different codes. And I will say the bottom bullet point is important. We were very concerned about whether participants would get copays. So we had a lot of discussion up front about if you're getting copays, we want to hear about it. We'll figure out a way to help you if it's excessive. We did some follow-up surveys actually 4 months after the program because we realized how late the charges were hitting people and plans. And we only had one participant who reported having charges passed along to them. They had a high deductible plan, and they actually were getting the full 99454 charge sent to them every month, $375. they were not very happy. And I managed to reimburse them through a faculty account kind of in a backwards way. But I think that's a concern for people with high deductible plans that we hadn't thought about up front. No other participants had any copays experienced. So in conclusion, I would say that this project showed that weekly RPM for people with type 1 is feasible using pop health dashboards that risk stratify CGM data. And it's potentially beneficial for people who are experiencing elevated glycemic measures. I think there's still a lot to work out. And I say that at the end of every RPM project. I hope in the next one I'll be able to say it's all worked out, but there are still things to figure out, right? So there's staffing limitations, there's variable responsiveness by our patients and families, and then the questions remain about variability in reimbursement. So with that, I will take any questions.
Thank you so much. The floor is open for questions. Yes, Janice. And while the microphone comes to you, I got text message saying that why pediatricians don't use Eversense because it's not approved. Come on, folks. We all do off levels and type 1 diabetes all the time, okay? I didn't say that, but I'm just saying. All right, Janice.
Thank you, staff. This is a great project, and to the Tidepool team, Janice Wong from UCSF. So I have a bunch of questions, but I'll try not to ask all of them. First is clarifying, because this was a dashboard, everyone had to be using CGM at baseline, or did anyone start CGM new to participate?
No, they had to be on CGM, and I required them to have been on it at least 3 months so that they sort of had things moving.
And then you might have mentioned this, but I might have missed it. Did you do analysis of those who did not respond to the messages in terms of their outcomes compared to those who did not, or those who engaged in terms of your weekly or however frequency versus those?
Yeah, it's a good question. I'm looking into that next. I haven't done a formal analysis of it in this. I will say, based on the prior projects I've done, it's tricky because often the people who get the most touch points and we spend the most time on are the ones who are struggling the most. And so a dose response is hard to show, right? And so often it's the patients who I ended up calling them. I had patients who we lost track of, and I was hunting them down through like schools and spending all this time and talking to them, you know, for an hour with an interpreter, but they may not have had amazing outcomes. And you don't know what without a comparison group and without a randomization, you don't know whether it would have gone differently without that. And then some people who met the baseline A1C criteria, but maybe weren't struggling that much, didn't really need outreach and did fine. So it's a little tricky.
Yeah. So, and then the last one for now, and maybe we'll talk more later, but non-CGM outcomes, did you assess in this population in terms of, you know, you have all of the really great and wonderful, I think, changes in your times in range, but like their perception, maybe I missed that too, but of just participating in the program and having their frequent follow-up.
Yeah, so I mean, we did the survey. Oh, sorry, I'm going forward instead of backwards. We did survey people. There's more survey data than just this. This were just a few of the highlights, but people in general were really satisfied and wanted to continue in RPM, even the people who hadn't had much contact, which was interesting. And they perceived it as helpful for a lot of things, mainly just reminding them about diabetes. And that's what I've seen through my other sort of extra care programs too, is people say it just helps me to have another touch point, and it reminds me to keep diabetes priorities up between visits. We actually thought this would be most helpful for things like CGM supply issues and just detecting when people were off CGM, but it turned out it was more useful to them just as the extra reminders and touch points.
Yeah, because I'm wondering if some of these outcomes, and if you were to look at validated measures, if this is just as valuable, if not more valuable, than just looking at the glycemic outcomes, and if we're to do this all over time. But this is really great. I'm really excited to hear.
Well, and if anyone has thoughts on what measures to look at, because I have a research study that's going to be published soon where we actually did, with validated measures, look at diabetes distress and other things with extra touch points in RPM. And those didn't seem to budge either, even though people reported high satisfaction. So I think it's figuring out what we need to measure to really like put our finger on it, you know?
Stephanie, great project. This is Millie Vicaria from Texas Children's Hospital, Baylor College of Medicine. Quick comment that Dr. Daniel DeSalvo at Texas Children's is very well known for running the RPM program for our institution. questions for you. One, did you have any patients who are publicly insured and any hurdles getting insurance coverage for those on Medicaid? And then two, oftentimes CGM billing is done once a month, or insurance will cover it only once a month charge. So how did you sort of overcome that?
Yeah, great questions. And I'm glad you brought up Dan. I have a soft spot for him. He was my co-fellow. So we're lucky in California that Medicaid, our Medicaid program has an affiliated program, California Children's Services, that provides extra coverage, and it does cover these codes. So all of the public reimbursement data here is pretty much it's our Medicaid reimbursement data. So it's low amounts, but they do cover it. I actually was doing this project in collaboration also with Todd Alonso at Barbara Davis Center. He's doing a parallel project. Colorado Medicaid has not been covering these codes, but is about to. So it really depends on your state where they are with covering the RPM codes. These codes also can only be dropped once a month. So we didn't use the 95251 for CGM interpretation, but similarly, these are once a month codes. So we actually have a encounter in Epic that we would open on the last day of the month, total up the time spent, put in the billing codes and an attestation and show the data reviewed. And then at the end of every month, we would send that through. That's a great question.
Hi, Stephanie. Francesco Andrame from Miami. So, nice project. So, I have a question. How did you determine the number of visits for each patient? So, was this decided before starting and it was a fixed schedule, like once a week, once every 10 days? And then another question is how much time do you think it took for each patient, beside the time for reviewing and the encounter with the patient? But I mean, reaching the patient and whatever was coming together.
Yeah, thank you for that. So we looked at the cohorts data every week, and then we reached out to anyone who met these criteria. So it was a weekly cadence, but not everyone was getting outreach every week. And then in terms of time spent, I mean, thanks to the Tide dashboard, actually identifying the patients to reach out to was really quick, right? That's the beauty of these amazing pop health dashboards. It shows you who meets criteria, but the time spent actually getting in contact with them and having the conversation and helping them with what they need was super variable. So again, the median was 10 minutes, but it ranged from 5 minutes to 60 minutes, depending on the patient and what was needed and what was going on with them. And that's the other thing is I think, I know I'm probably over time, but one more comment. When you think about RPM in a new onset population, which I've done as well, and which 4T has done amazingly, a lot of it is dose adjustment, right? And you can look at stuff, you can send them dose adjustments over EHR. When I've done RPM in existing patients who are struggling with glycemic levels, there's a lot more you have to drill down and figure out. It couldn't just look at something and say, here's a message, change these doses, and they would do it. It was a lot of a conversation and getting them on the phone and figuring out what's going on and making behavioral recommendations or coming up with strategies. So it's a different beast. Yeah.
Right. We have one question online. How often do you get a claim denied versus approved for reimbursement? And is the denial more often found for patients with public insurance?
Great question. I should have crunched that percentage number for this to tell you what percent were denied. In our population, it was not the public insurance that was denying claims because California Medicaid covers these codes. So for us, it was all private insurance plans that denied the claims, and it was just payer specific. So I don't have the number off the top of my head, but I should calculate that percentage, and I'll have it at some point. Yeah.
Hi. If we can have one last question. Carla from Rady Children's Hospital, San Diego. So predicting that this is going to be integrated in clinical care one day, hopefully, can you make any comments in the perception of the staff, the nurses that normally receive those calls? How would they take, because now you're more proactive, you're calling them. Are you decreasing the number of calls that we are receiving in our, triage calls?
The truthful answer is I don't know. I think we need to figure that out. I've struggled when I've done this in a research setting and then even as this clinical pilot, I've struggled to figure out how to integrate it with the rest of our team. Our nurses are overwhelmed, as I'm sure everyone's are. And so I initially thought, oh, the navigator will reach out. And then when they need something, they'll pull in the nurses. And the nurses were like, that is not on my radar right now. I have so much else. You need to talk to Dr. Crossen. So it was, I don't yet know how to seamlessly pull this in. I think there's great potential for it to cut down on the extra work they're getting in their inboxes and to make it all more proactive, more individualized for what patients need and reimbursable. That's the goal, but I don't have all that figured out yet.
All right, thank you so much, Stephanie, for a wonderful presentation. So when I was looking at the session title that says GLP-1 and adjunctive, I was really looking forward to that. It sounds like a decoy to get you in and stay with me for 1 hour. But last presentation is about that. By the way, all 3 presentations were great. Okay, just all right. So the last speaker is from Indiana University, Noha Yaman, and she's gonna speak about the GLP-1 choices and change patterns in a pediatric type 2 diabetes in Indiana.
Hello, good morning. Happy to be here. So my name is Noha. I'm a pediatric postdoc research fellow at Indiana University, and I work with Dr. Hansen. And I'm very happy to present our project on GLP-1 receptor agonist choice and change patterns in pediatric type 2. So as we all know, pediatric type 2 is rising, and GLP-1s have been increasingly used to improve glycemic control and weight outcomes. And despite this growing use over the past few years, real-world pediatric data about, choice, switching, and discontinuation remains limited. So in our project, we aim to characterize these prescription patterns and identify reasons for switching and discontinuation in our population of pediatric type 2. So this was a retrospective chart review at our Peds Endo Clinic over the course of 6 years. We included patients aged 7 to 18 who were diagnosed with type 2, and we abstracted visit level data on both demographics and GLP-1 prescriptions. So we had a total of around 850 patients who came to the clinic 3,400 times. 60% were females, and the majority were insured. They had public insurance, followed by private insurance, and a negligible number were self-payers. So over the course of 6 years, we had 37% of visits ending with a GLP-1 prescription. So zooming in on the graph on the left, 3 main things to note. If you look at the small box on the bottom, which I don't think you can see back there, but I'll try to tell you some of the numbers. So looking just first at clinic visits, in 2019, we had around 260 visits, and that increased to 780 visits in 2024. Then looking at the height of the bar graphs, which illustrates the number of visits that ended with a GLP-1 prescription, and focusing on the axis on the left, which shows the numbers, it increased. So was this increase actually due to an increase in visits, or were more visits ending with a GLP-1 prescription? Well, I'll direct you to the line graph, which actually shows the percentage. In 2019, around 10% of visits ended with a GLP-1 prescription. That increased to around 21% in 2022. And then right at 2024, we have 63% of visits ending with the GLP-1 prescription. Looking at the pie chart on the right, overall, prescriptions over the past 6 years, 60% of the scripts were just continued scripts, followed by new scripts at 27% and switched scripts at 14%, which is to be expected now that GLP-1s have become more established at the practice. Then we go on to look at GLP-1 prescription composition, looking at what agent providers chose to prescribe. Early on in 2019, you can notice the blue that designates dulaglutide, and the red designates liraglutide. So they were really key players in 2019, but liraglutide, the red one, sort of took over in 2020 and 2021. And maybe side note, you can kind of guess why. Maybe we'll talk about it in the end. In 2022, we have this emergence of the green, which is semaglutide, and then which continued to obviously 2023 and 2024 with minimizing utilization of liraglutide, again, the one in red in the last 2 years. So looking at the new prescriptions, so what was the agent that was prescribed to patients as the first GLP-1s? Mainly it was dulaglutide at 43%, followed by semaglutide at 29% and liraglutide similarly at 25%. So this was the agent that was chosen to be prescribed as, the first introduction to GLP-1s for that patient. Moving on to GLP-1 switches, you have this heat map. On the left, you have the from agent, and on top, you have the agent that the patient was switched to. Looking at the really dark blue lines, we can first focus our attention on the switch from semaglutide to dulaglutide, which was our most common switch. And that was mainly due to insurance. At around 90%, that was the driving reason for patients to be switched from semaglutide to dulaglutide. Then focusing on switches from dulaglutide and liraglutide to semaglutide over on the right, that was mainly due to the weight loss benefit that was found in semaglutide as a drug. And finally, the switches from liraglutide in general to all the different agents, looking at the third row, mainly liraglutide was switched to both dulaglutide, exenatide, and semaglutide, and that was mainly due to also insurance, but also adherence, given that liraglutide is a daily injection. But taking it overall, the main reasons for driving a switch were insurance at around 50%, followed by weight loss benefit and some unclear reasons at the chart. Other reasons that we might think, like availability issues, side effects, adherence, and treatment plans, were contributors, but they weren't the main ones. Switching over to GLP-1 discontinuation, it was discontinued at 58 visits. Here we see an emergence of two reasons, like patient preference and side effects, and they were key drivers to discontinuing GLP-1s, while previously I told you that they had a really minor role in switching, but insurance is also a key player here. So in conclusion, in our study, in our cohort, dulaglutide was the most prescribed and most frequent switch target among pediatric type 2 patients. Insurance coverage was the leading factor in medication choice at the beginning, and switches often overriding clinical preference. And other factors like perceived efficacy, tolerability, and side effects played a role, but to a really lesser extent. Thank you.
Okay, thank you so much. And any questions? I can start with at least, so when you say the continuity of prescription, is that a prescription or it's the patient taking it? Like how did you look at those prescriptions through just the drug list?
So looking at the individual visit level data, looking if the patient had been taking the medication and if it was renewed. So that designated a continued prescription.
Okay, that means that they were taking it and they were continuing. So that's a good data, yeah. And I'm assuming that the terzepatide is still not commonly used. It's because it's relatively newer agent than other agents, and it's taking a time for prescriber.
You can see it in the
percent.
that was mainly from patients who were on clinical trials and also followed up at clinics. So it's a really minor contribution.
Hi, Janine Sanchez, University of Miami. You mentioned that some people switch because of not sufficient weight loss. What about diabetes control? Were there anybody switch for that reason?
Yeah. So on the left, you can see treatment failure contributing to 3%. So so in the chart, it was designated as either wanting to switch for a weight loss benefit. Mainly, they were switched to semaglutide, but they were also switched to other agents very rarely, or they were designated as having failed treatment, and that's why they had switched them to another agent.
Grace Kim from Texas Children's. Any issues with getting the semaglutide covered?
Mm-hmm. So as you can see with the switches, semaglutide, the main reason for switching out of semaglutide was insurance, about 90%. And I think the data honestly underestimates that, because sometimes providers wanted to prescribe semaglutide, but they knew that it wouldn't get approved. So, and that was sometimes written in the charts, but also what I know anecdotally. And so I think insurance is a really big role, and the data does show it, but I think it also underestimates it.
Shah, grandchildren. How often would you see this patient as a follow-up in a year?
So again, I'm a postdoc. I don't see the patients, but from the charts, usually patients are started off at 3 to 4 month intervals, sometimes progressing to 6 months, 8 months, or 12 months, depending on glucose control.
Hi, this is Praneet Brar. I'm calling from NYU Long Island. This was really helpful.
Extend this project to really look at the efficacy of these different agents over time, and what happens in terms of both A1C as well as the weight loss would be an extension of this project.